Hello, my name is Adam Singer. I'm from Atlanta, Georgia, and today I'm going to be discussing imaging of the brachial plexus following trauma, and I'll be emphasizing MRI and MRI neurography, though I will touch on a couple of other imaging modalities. If you'd like to see more information about this topic, feel free to look up this paper where we review this in a little bit more detail. So today's talk will have three learning objectives. First, to understand how each imaging modality can be used to assess for brachial plexus trauma, to characterize it, and to understand the strengths and weaknesses of each imaging modality. Second, we'll see examples of the normal and abnormal appearance of the brachial plexus and the terminal branches as they run through the arms. Finally, we'll become familiar with the management strategies for brachial plexus trauma and trauma to the upper extremity peripheral nerves. This will just scratch the surface and will be a very, very small overview of the management of these injuries. So to start, we'll begin with CT myography. This is where intrathecal iodinated contrast is injected and a CT scan of the spine is performed. The advantage of this technique is that there's excellent spatial resolution, so we can really resolve those small dorsal and ventral nerve rootlets exiting the spinal cord. The disadvantages include the need for exposure to ionizing radiation, the invasive procedure required before the CT scan is performed, namely injection of iodinated contrast into the thecal sac. If the patient has an allergy to iodinated contrast, this may also be a limitation. And finally, CT technique unfortunately does not have the soft tissue contrast necessary to accurately assess and characterize postganglionic injuries. High-resolution ultrasound is another imaging modality used to look at the peripheral nerves. There are several advantages and disadvantages. In the advantage column, the probe, when it's closer to superficial nerves using high-frequency linear transducers, allows for better spatial resolution than MRI. It's a fast imaging modality and does not require the use of ionizing radiation. We can assess for dynamic changes of the nerve, such as impingement or snapping. We can determine if a structure is solid or cystic, if it has blood flow in or around it. This is an excellent imaging modality for claustrophobic patients that cannot tolerate being inside of a magnet for 30 to 60 minutes. This can be used to guide diagnostic nerve blocks if a nerve is suspected in terms of causing pain for a patient. And we can use the other nerves or the contralateral side as a comparison, assuming the other side is not affected, and we can quickly scan the entire course of a nerve. There are several disadvantages. First, and probably most important, is that it's operator dependent. Unlike the MRI or CT scan, the operator who's actually doing the scanning must be familiar with the anatomy and understand it. They must also be able to accurately depict what they're seeing and record these images, so they'll have to know how to use the machine. Ultrasound also does not allow us to, quote, see edema in the nerves like we do on MRI, so that T2 signal that increases when we see injury, we cannot see with ultrasound. The soft tissue contrast is poor considered or compared to MRI. One major issue is that while we have good spatial resolution when objects are close up, as things become deeper and deeper in the body, we limit our ability to see with high spatial resolution. So we decrease the frequency, lose some spatial resolution to penetrate further down. And so this is not very helpful if the nerve is buried under, say, 5 to 6 centimeters of adipose tissue or muscle. Along the same line, if a nerve is located behind a bone, such as the clavicle, it can be particularly problematic to see the nerve if the sound beam cannot pass through the bone and back to the transducer. Finally, we cannot, quote, see edema in the muscle like we do with MRI, so the early denervation changes that we see with the increased T2 signal, we don't see. We may see loss of bulk or increased echogenicity when there's fatty infiltration. MRI also has advantages and disadvantages, the advantage being the better soft tissue contrast. That's very, very important. It has the best soft tissue contrast between these three imaging modalities. We can, quote, see edema in the nerve, so this is represented as increased signal on fluid-sensitive pulse sequences, T2, STIR, and if we're using more advanced imaging techniques, we may see a decrease in the fractional anisotropy when nerves are injured. There is no ionizing radiation. We can do 3D imaging and create maximal intensity projection and multiplanar reformatting type images so that we can really lay out the entire course of a nerve within our field of view. We do have the ability to see nerves that are deep in the body, so that's an advantage over the ultrasound. When a patient cannot tolerate an EMG study, we can look for denervation changes in the affected limb. I'll describe this in a little bit more detail. Disadvantages: this is a time-consuming procedure. The patient has to be inside of a scanner, sometimes between 30 and 60 minutes, maybe even more so if you're adding on additional sequences, and especially for a claustrophobic patient, this is a difficult task to do. There's a sensitivity to different types of artifacts as well. So sensitivity to motion, for example, will really limit our ability to make accurate diagnoses. If there's metal in the field of view, that's going to cause a significant problem as well. The spatial resolution is not as high as ultrasound for these superficial nerves. We do have less dynamic capability when compared to ultrasound, and though this is not relevant to trauma per se, if you see a mass around one of the nerves, it may be difficult to differentiate a cyst from a small solid myxomatous mass, and so you really need contrast to help differentiate the two, and when you don't have contrast, that can become problematic. So this is an example of a CT myelogram here on the right. We see the intrathecal iodinated contrast in the CSF space here is hyperdense, and then we see the hypodense ventral and dorsal rootlets coming out of the spinal cord and heading toward the neural foramina. In this same patient at the same level, we see on our MR myography image here this heavily T2 weighted pulse sequence. The CSF is T2 hyperintense or bright, and we see the hypointense ventral and dorsal rootlets coming out of the spinal cord and heading toward the foramina. So these show very similar findings. Secondary signs of brachial plexus injury include denervation in the paraspinal muscles when it's preganglionic, cord edema, hemorrhage at the site of trauma, blood products in or around the neural foramen, and pseudomeningocele. So pseudomeningocele are these nerve sleeve injuries where you see CSF extending out into the foramen, sort of ballooning out. And so when we did conventional myelograms, when you couldn't actually do the CT, this is before CT, you were looking for these pseudomeningocele as evidence of a preganglionic rootlet injury. And several papers have described the utility of the pseudomeningocele finding, and the references are down here. But pseudomeningoceles, 20% of rootlet avulsions may not have them, while 15% of pseudomeningoceles may not be associated with complete rootlet avulsions. So things to keep in mind: you really want to use either a CT or MR myelography protocol to directly visualize the rootlets exiting from the spinal cord and heading toward the neural foramen. You may see some of these secondary signs as evidence of preganglionic injury in lieu of the pseudomeningocele, and this is an example here, a patient who had a mixed pre- and postganglionic injury. At the C8 and T1 levels, we see the preganglionic portion, so both imaging modalities showing thickening of the ventral rootlets coming out of the cord heading toward the affected side, and complete effacement of the foramen with this soft tissue material. At the T1 level, you see the ventral and dorsal rootlets on the unaffected side, and then again this soft tissue here with non-visualization of the rootlets on this side. Now I acknowledge it'd be easier to show this scrolling through the images, but there were no rootlets on this side. So high-resolution ultrasound, just a little bit about the technique. I recognize that this is not in the arm or upper extremity region. This is in the leg. We're looking at the sciatic bifurcation, and using this example just because it's a nice example that I had showing the same patient with MRI and ultrasound. So when we talk about short axis and long axis, these are terminology concepts that you have to get down when you're dealing with ultrasound of the nerves. Short axis, it's the cross section, and the nerves will look like a cluster of grapes. So these hypoechoic rounded fascicles of nerves surrounded by hyperechoic or echogenic connective tissue, and I've highlighted them in yellow here. This is the common peroneal nerve and the tibial nerve after the sciatic nerve bifurcates, and we're seeing the same thing on the MRI here. And to strike home this concept of the spatial resolution, I put these two images side by side. You can see individual nerve fascicles very well with the ultrasound, but here they sort of blend together on the MRI. And part of that is because the majority of the MRI image that we look at here is not represented by nerve. In fact, more of it is adipose tissue, muscle, femur, tendons. It's just a small part of the pixels on this picture that represent the nerves. And so you see this is the common peroneal nerve here, where you really have a difficult time differentiating the fascicles compared to here, and the same thing with the tibial nerve here compared to here. Getting back to the terminology, in long axis it's been likened to cables with hypoechoic parallel fascicles surrounded by the hyperechoic connective tissue, and so here you see the sciatic nerve outlined above the bifurcation with the overlying and underlying muscles. This is also not a case of trauma, but we're looking at the median nerve in a patient with type 1 neurofibromatosis, and you can see some of these normal fascicles in cross sections. This is short axis, but then you see this ill-defined infiltrative hypoechoic material in the nerve, and as I scroll through here, you're going to see that that will disappear, that neurofibroma we're passing now, and we get down to a point where you now start to see normal internal architecture, parallel cross sections of hypoechoic nerve fascicles surrounded by echogenic connective tissue, the cluster of grapes, and then as you keep coming forward, now you're seeing more neurofibromas infiltrating this nerve here and distorting the normal nerve ultrasound anatomy. So normal versus abnormal nerve architecture in this case of a patient with type 1 neurofibromatosis. We have a teaching atlas that we use side by side comparing the peripheral nervous system in the upper extremities ultrasound to MRI, and so on the MRI you again see this small field of view represented on the ultrasound, and you can see the radial nerve fascicles much better than you can see here on the MRI. Similarly at the elbow, now we're looking further down, the radial nerve is starting to split into the superficial sensory branch and the deep or posterior interosseous nerve, which is the motor branch, and you can again see that nicely on the ultrasound. Further down, we see the ulnar nerve at the cubital tunnel. You see it right here. And in this case, the ultrasound showing the normal cluster of grapes appearance where you see the fascicular architecture maintained. This is the medial humeral epicondyle right here and here. And this is volar or anterior, medial, posterior, lateral. In this patient with ulnar nerve and a suspected snapping nerve condition, you see in extension the ulnar nerve is still in the cubital tunnel. It's posterior to the medial humeral epicondyle, but it is high. So this is suggestive that there may be a deficiency in Osborn's aponeurosis or fascia holding it in place at the cubital tunnel. With MRI, we image in full extension, and so we don't get this dynamic appearance, and the dynamic change happens when you go from extension to flexion, and so with ultrasound we're able to watch this change happen. So in this clip here, as we go from extension here, as you would see on the MRI, to flexion, you see that nerve snap anterior or volar to the epicondyle, the triceps following behind. So this is a snapping ulnar nerve due to a deficiency in Osborn's aponeurosis there. This is something we would not see under normal circumstances, and it causes chronic nerve irritation, and you see that distorted internal nerve architecture here. So MRI neurography is a term that has become very popular. There's really not an official definition of what this is, and each institution does their protocol slightly differently, but the majority of places will use a combination of 2D and 3D imaging, and will have some sort of fluid-sensitive, fat-suppressed imaging technique to look at the nerves as they head toward the shoulders. So at our institution, this is our current protocol. We do a stir space. This is a 3D image that we use to create MPRs and MIPs, as I mentioned before. Some places use a protocol such as this to suppress some of the signal from flowing vessels. a T1 without fat suppression, and then a 2D in plane sagittal oblique image. And we're going to be using thin slices, and you may either use PD fat set or stir depending on whether or not you're having problems with field inhomogeneity and fat suppression. So these are some examples of non-traumatic findings on brachial plexus MR. This first one, radiation therapy, and you see the smooth increased signal and caliber within the radiation port. This patient with genetically proven Charcot-Marie tooth type 1A with a symmetric bilateral smooth enlarged brachial plexus, breast cancer metastasis with the corresponding increased FDG uptake in this area, and a pancreas or superior sulcus tumor coming from the lung and heading up into the region of the lower brachial plexus and surrounding C8 and T1. This is an example of an MR myography study, again heavily T2-weighted 3D imaging, and the CSF is going to be hyperintense or bright. On the unaffected side, the ventral and dorsal rootlets coming out of the spinal cord going toward the foramen, the dorsal root ganglion out here. On the affected side, the ventral rootlets are injured. There's thickening and abnormal morphology as it heads towards the foramen, which is filled with more of that material. Finally, we do what we call MR myography. So these are a stack of thick imaging, usually stir, so we can get the best fat suppression that we can get. And we're not necessarily looking for the nerves, but we're looking for the effects of injuries of the nerves downstream. So the muscles that are innervated, do we see denervation changes? And in this case, yes, we see denervation change in the extensor compartment of the forearm, suggesting a radial nerve injury. Contrast always comes up when we discuss MRI, and particularly MRI of the brachial plexus. And in the setting of trauma, it's generally not necessary, but we do have several indications that we do use contrast routinely for. And so one of those is looking for tumor or trying to differentiate recurrent tumor from radiation change. And so this is a case here of a patient who had a synovial sarcoma around the brachial plexus, and you see this rim-enhancing cystic structure with a smaller internal cystic structure. We turn sagittal on it, and you can see in the post-contrast there's some enhancement within this smaller cyst, and you can almost make out a fluid level right there. The ultrasound, again, better resolution, shows that fluid level in the dominant cyst, and in the smaller cyst we see internal flow. This was biopsied and proven to be recurrent synovial sarcoma. Of note, there is debate as to whether or not neuromas in continuity enhance or not, and so some people have thought about whether or not this can differentiate, say, a nerve tumor or a tumor near the nerve to a post-traumatic neuroma in continuity. So this is something that will probably be worked out in the future. Thoracic outlet syndrome protocols often will use contrast for the MRA, so they may do arms up and arms down, looking for narrowing around the vessels. Some investigators are developing techniques with contrast to look at the nerves, and there is a possibility that this would be helpful in the setting of inflammatory or demyelinating lesions looking for injury to the nerves. So just to review the brachial plexus anatomy, when we talk about the brachial plexus, it's typically originating from C5 through T1, although there is some variation with contributions occasionally from C4 and T2. The ventral rootlets come out of the spinal cord, and those are going to be the ones that contribute to the brachial plexus. And after the dorsal root ganglion, there is a segment before you get to the trunks where we still call it the roots, but it is postganglionic. So we sometimes call it the anterior rami or the primary ventral rami. I'll call them the anterior rami for the rest of this talk. But note that there is a portion lateral to the dorsal root ganglion, but before the trunks, and that is on the Netter diagrams in the area of the roots. The C5 and C6 anterior rami will come together to form the upper trunk. C7 continues as the middle trunk, and the C8 and T1 anterior rami will become the lower trunk. The posterior divisions of all three trunks will come together to form the posterior cord. The anterior divisions of the upper and middle trunks will come together to form the lateral cord, and the anterior division of the medial cord will continue. The anterior division of the lower trunk will continue as the medial cord. Of note, there are several nerves that come off before the terminal branches, and so we'll note just a couple of them. Off of the anterior rami from C5 through C7 is the long thoracic nerve that innervates the serratus anterior. The suprascapular nerve off the upper trunk to the supraspinatus and infraspinatus, or the rotator cuff muscles. You may see nerves coming off the posterior cord, the upper and lower subscapular nerves to subscapularis and teres major. And then we come out toward the terminal branches. And so the terminal branch off the lateral cord is the musculocutaneous nerve, primarily to biceps and brachialis, elbow flexion and helping with forearm supination. And then there is a terminal branch off the medial cord, the ulnar nerve, but off both the medial and lateral cords, there's going to be contributions giving rise to the median nerve. Off the posterior cord, the larger terminal branch is going to be the radial nerve, the smaller one out here, the axillary nerve. So this is to teres minor and deltoid. This to a bunch of the muscles along the dorsal aspect of the arm and forearm / hand and wrist. So this is a teaching atlas that is available on the YouTube channel, labeled on the right, not labeled on the left. So we're going to follow C5 and C6 first. They're going to come together. Here's the scalene muscle here. And they're going to fuse and become the upper trunk here. We go back and you're going to see C7 coming out as itself and continuing as the middle trunk. And you're going to see C8 and T1 coming toward the lung apex and eventually coming together to form the lower trunk. Now, this is one of those areas where you have problems with artifact, right? The lung apex, you see this failed fat suppression, and for a couple of clicks through, it's very hard to see the nerve there, that T1 coming over the lung apex. So just keep that in mind. So now we're at the level of the trunks, and you're going to see them starting to split into the divisions. So you're going to see an anterior division here and a posterior division here, anterior, posterior, and anterior, posterior. So we're going to follow the anterior divisions of the upper and middle trunks first. They will come together out here to form the lateral cord. So here comes the anterior upper, anterior middle. We'll watch these two, and they're going to come together and form the lateral cord right here. We're going to back up, and now we're going to follow the posterior divisions of the trunk. So posterior, 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 and they will come together to form the posterior cord right there. And then the anterior division of the lower trunk will continue and form the medial cord. And so a good place to stop and look is right around here. So the cords surround the axillary artery, and at about 10 to 11 o'clock you're going to see that lateral cord anterior to the artery. Sitting right on top, sort of like a little hat, you're going to see the posterior cord. This is generally about 12 to 1 o'clock. And then near 3 o'clock, posterior to the artery, you're going to see the medial cord. We'll follow the lateral cord terminal branches first. So the one that comes off by itself and goes through the coracobrachialis is going to be the musculocutaneous nerve right there. We'll follow this back. This is the lateral cord median nerve contribution. So you're going to see that come back to the lateral cord. And if you follow on the medial cord, you're going to see the median nerve contribution here. They're going to swing around that axillary artery, fuse together, and become the median nerve right there. Then we follow the other one back, so this is going to follow back to the medial cord. This is going to be the ulnar nerve right there. And finally, let's look at the posterior cord. So the smaller one's the axillary nerve. That's going to go towards the quadrilateral space, turning posteriorly, while the radial nerve, the larger one, will continue into the arm with the other nerve. So we can see that axillary nerve turning out toward the quadrilateral space there, and the radial nerve continuing with the artery and the other nerves down into the arm. So historically, Seddon and then Sunderland tried to describe the histological findings associated with injury to nerves. Seddon described a three-tier system: neuropraxia, axonotomesis, and neurotomesis, whereas Sunderland had 5 degrees of injury. This has been revised somewhat more recently, where you can have mixed type injuries as well. For neuropraxia or first-degree injuries, this is where the myelin sheath is injured, and you do not have the axon being cut, so there's no layering degeneration, there's no denervation change. And so on MRI, you may see some mild thickening of the nerve fascicles and increased T2 signal, but the muscles downstream should be normal. We would expect a full and rapid recovery in this case. For second and third degree injuries or axonotomesis and getting towards neurotomesis, you're having increasing degrees of injury of the axons plus the surrounding connective tissue. So the axons are cut and layering degeneration occurs, and so you end up getting denervation change downstream. It's somewhat difficult on MRI to differentiate second and third degree injuries, but you will see thickening and increased T2 signal, generally more than first degree injuries, and you see the denervation changes. So if we come over to the image here of the nerve anatomy, you see these fascicles here, and these are the hypoechoic bundles we're seeing on ultrasound, but note that the fascicles are actually made up of numerous axons running in them. They're surrounded by endoneurial tubes, each of these axons, and then there's perineurium surrounding the fascicles here and holding them in place, and there's loose connective tissue in between. And then on the outside of the nerve is the epineurium. So with increasing degrees of injury, you first have the axon, then you get the endoneurial tubes, and then you start getting the perineurium partial, you get epineurium partial, and then complete epineurium is a complete transection. So a fifth degree, the entire nerve is discontinuous. Whereas a fourth degree injury, this is sometimes referred to as a neuroma in continuity, and this is where you have a partial transection. The nerves attempt to regenerate, but they can't reach where they're supposed to go. Scar tissue forms, and the nerve is still continuous, but you see a focal bulbous mass almost in continuity with the nerve, and that's the neuroma, that scar ball and disorganized tangle of axons that attempted repair. And so prognosis is much worse with both of these, the fourth and fifth degree injuries, compared to the first through third. So the clinical relevance: acute sharp transections, such as a stab injury, you may have a surgeon who goes in, primarily explores and repairs the nerves right then and there. But the majority of these end up being blunt or distraction or compressive type injuries, and so typically delayed management is what's done. The surgeon and neurologist will typically give a trial period of up to 6 months to assess for physical exam and electrodiagnostic evidence of ongoing recovery. Keep in mind that peripheral nerves grow at a rate of about 1 millimeter a day. At around 6 months, if there's not meaningful recovery, this is when we're going to start looking into surgical correction to try to have better outcomes. But if you wait to 18 months, often, even if that axon on its own gets down to the muscle and attempts to reinnervate, you're going to have atrophy and scarring at the motor end plate, preventing a meaningful recovery. And so you're trying to get whatever is going to be done to reinnervate that muscle by that 18-month period. And the management strategies are numerous. We'll touch on a couple, but nerve transfers are one type that is gaining success, and I'll go through that in a little bit. Nerve grafting, nerve supercharging, nerve conduits. Later, if this all fails, or if there's not a good nerve transfer donor, tendon transfers are another option, and then all of these surgical interventions will require physical therapy to retrain the patient to use these muscles like they were not designed to be used. So this is an example of a nerve transfer surgery. In this case, I'm going to show a cartoon illustration of the double Overland nerve transfer. So this is used for isolated upper plexus injuries, C5-6, or the upper trunk, and what you knock out when this happens is the suprascapular nerve, so you lose the ability to externally rotate the shoulder and limit your ability to abduct the shoulder. And then you lose the musculocutaneous, so flexion at the elbow is limited, and there's also a limitation in forearm supination. But you do have multiple other nerves that are working and potentially could act as donors. So axillary, radial, ulnar, median. So in this case, this crude drawing here showing the injury and the denervated muscles, but you do have intact median and ulnar nerves, and inside of those you have fascicles going to innervate the flexor carpi radialis and the flexor carpi ulnaris. And so what they're going to do is they're going to open up these nerves, and they're going to use electrostimulators to find the fascicles that cause those muscles to fire. When they find them, they're going to sacrifice them. They're going to disconnect them from the median nerve, flip them toward the biceps and brachialis, and they're going to sew them together. The reason for doing this is twofold. Number one, there's redundant innervation from other muscles to allow you to continue to flex at the wrist. So even when they do this, you'll not lose all of your wrist flexion. Also, to relearn the function, because you're now going to have the nerves that used to be causing you to flex at the wrist, causing you to flex at the elbow. Flexion at one area is a little easier to relearn during the physical therapy when it's flexion at the other area. So they go in, they find these nerve fascicles, they disconnect them, and then they disconnect the musculocutaneous branches to the biceps and brachialis and sew them together. And so remembering that we're going at about 1 millimeter a day, if you have a high injury up here, you are racing against the clock to get all the way down to the elbow and reinnervate by that 18-month period. But if you do a nerve transfer surgery, you've got healthy axons all the way down here, and so really the growth is just going to be across this point. Even if you have a Ulnar generation, they have to grow back and grow across this point and then reinnervate right up against the neuromuscular junction here, so the motor end plate. So it's a much shorter distance to grow, and so within that time period, the likelihood of getting to where they need to go is higher. And so the Medical Research Council scale is a scale that is used to quantify the degree of muscle function. So 0 is no movement, 5 is normal strength. MRC 3 and 4 are considered good outcomes, and so this was from a systematic review of 33 studies looking at recovery after primary repair, nerve transfer, and repair plus transfer. And if you look at those achieving MRC 3 or greater and 4 or greater and compare at the elbow and shoulder, repair versus transfer, you can see that the transfer beats out the primary repair in both sets. And then adding on the repair to the transfer really doesn't contribute that much. And so a lot of the focus, especially for isolated upper plexus injuries, has shifted towards these nerve transfer surgeries. As I mentioned before, the Overland down at the level of the elbow to reanimate there, and then sometimes spinal accessory to suprascapular nerve to try to reanimate the shoulder. One pitfall that you may run into is when imaging is performed too early. And so this is a patient who suffered a brachial plexus injury and was imaged a couple days afterwards, and you see that the whole area is obscured by edema or hemorrhage. This is not failed fat suppression. You can see good fat suppression in other places, so this is just what happens after the injury. The patient came back a couple months later, and now you can delineate the injured brachial plexus. Here's the upper trunk splitting into the anterior and posterior divisions here, the middle right here, and then the normal lower trunk down here. And you can see this bulbous appearance with increased signal, especially in the posterior divisions of the upper middle trunks. And here's the corresponding ultrasound showing this division into the anterior and posterior upper trunk divisions and the middle here. And you see the normal fascicular architecture in the anterior divisions, but the posterior divisions are abnormal, thickened. The architecture is lost, the lower down here. So now, just keeping in mind what we saw initially, we're going to follow this out and see how helpful it is to image later. So 5, 6, 7, 8, and 1 coming out, trunks, and now we're seeing this part with the divisions here, and as we keep following the divisions out, they thicken, especially the posterior ones. We see the anterior divisions okay, but these two, the posterior divisions, are thick, abnormal increased signal, and then the upper trunk posterior division disappears, and the middle partially disappears, and then you see a stump appear distally at the posterior cord, which also looks abnormal. The axillary nerve is abnormal. The radial nerve is also abnormal too. So this is suggestive of a high-grade injury to these posterior divisions, and indeed we see a transection on the maximal intensity projection image here with end bulb neuroma right there. Denervation as expected in the deltoid from the axillary nerve. We see some subscapularis denervation, remembering that comes off the posterior cord. We look at the deltoid on the unaffected arm. You see normal hypoechoic muscle and bulk compared to the affected side where it's echogenic and we've lost bulk. Downstream in the forearm extensor compartment alone, you have denervation change compared to the volar, which is going to be median and ulnar innervation. A electrodiagnostic study was performed which confirmed a posterior cord injury with nerve discontinuity, and the patient ended up having tendon transfer surgeries to try to fix some of these problems. This is another patient, so we're going to start with the ultrasound, and we're watching C5 coming out of the neural foramen right there, and next we see C6 coming out, and they're going to disappear right there. So they disappeared, and now you're going to see two nerves seemingly out of nowhere emerge, slightly inferior and lateral. So there's one, and then there's two. Abnormal morphology, no fascicular architecture, and as we keep coming out laterally, you're going to see nerves emerge anteriorly, and you'll start to see fascicular architecture as you get further out. So we knew we were dealing with a high-grade injury to multiple nerves. We did an MRI, and as you follow these nerves out, you see C5 and C6, and they are going to disappear right there, but those bulbous nerves, right inferior and lateral, are going to seemingly emerge out of nowhere. So right there, you see them emerge, and then as you keep going forward, you're going to see that anterior nerve emerge further out there, right there. So we're dealing with transections of C5, C6, C7, and T1. Transections of C5, C6, C7, and C8. T1 we can follow here, coming across the apex right there. We see denervation changes in the shoulder girdle. However, this patient has a full-thickness rotator cuff tear, so it's a little bit difficult to tell which came first. This is the maximal intensity projection image, and so as you come further out here, you see that transection of 5 and 6, those end bulb neuromas of 7 and 8 here, and as we keep coming anteriorly and laterally, you're going to see the retracted 5 and 6 over here, and then for comparison, the opposite brachial plexus, normal. So the still image is showing this retraction here, and so there's a gap of about this far between the 5 and 6 nerves. And we did MR myography, and we saw denervation involving all of the muscles in the hand, the forearm, and the shoulder. And the electrodiagnostic study was concordant, severe and ongoing panplexopathy without axonal continuity in all tested muscles. Another case here, so we're following the nerves out, and this is one of the examples of problems with artifact with the frequency selective fat set, and so while we often use the stirb, you can see loss of signal there. And the upper plexus, which is injured in this case, will just emerge out of the artifact right here, and you can see again the anterior and posterior divisions are abnormal, increased caliber and signal intensity, and we're coming out here and following them out. And these are just some still images showing the normal middle and lower trunks, the abnormal upper trunk, and abnormal anterior and posterior divisions. In this case, we also did MR myography looking for preganglionic injuries. So at C4, this is above the plexus in most cases, but you see on the unaffected side the ventral and dorsal rootlets coming out toward the foramen. You see this effacement, the cord's pulled over. At C5, similar findings, can't really tell if the preganglionic segment's intact, and at C6, the ventral rootlet looks injured. And just going through here on the video, you can see what we're seeing on these still images right there. So examples of preganglionic injuries in the absence of a pseudomeningocele. This was a mixed injury, however. You had those preganglionic injuries, but there's also postganglionic injury. You can see C5 and C6. C6 in particular thickened, distorted, coarse, narrow tapering right there in the middle, high-grade injury, and then downstream, when you compare it to the contralateral side, you can see that the affected nerves are hyperintense and enlarged. So just some still shots showing here, and here's the maximal intensity projection image that shows this a little bit better, and you can see this really inflamed and enlarged nerve coming down the left brachial plexus there. And we saw denervation change in this case involving the infraspinatus here, the deltoid further distally, and biceps and brachialis down the arm. So again, consistent with an upper plexus injury. So in summary, peripheral nerve imaging should ideally be tailored to the individual patient's clinical story, and the advantages of each imaging modality can be leveraged to provide as much information as possible. Second, if you had to pick one of these three imaging modalities, and you could only pick one, MR neurography or MRI tailored to assess the nerves would be the best imaging modality to assess both the pre- and post-ganglionic brachial plexus better than any of the other imaging modalities alone. Thank you very much. This will be the first of several videos on the channel. I hope you will throw some likes up there, subscribe to the channel. I'll be putting out more of these videos in the coming weeks. Thank you.